So the one concept I want you to know about is airway wall remodeling. If you remember, one of the problems with asthma is that we think of it as an acute disease because patients present acutely with symptoms, but it is a chronic disease of chronic inflammation. If you remember back to the first few weeks of pathology when Dr. Latham taught you about acute and chronic inflammation is what first sets in, but when it becomes chronic, that becomes bad. Collagen sets in and you basically get scar tissue. And that's what happens in your lungs with chronic inflammation asthma. This is a biopsy study looking at patients with asthma of mild, moderate, and severe severity compared to healthy patients, and even the patients with a mild asthma had a thicker basement membrane, again likely due to sort of chronic inflammation. The good news is that inhaled corticosteroids actually work. This is the slide I showed you before, and after treatment with budesonide you see improvement. This next study has not been replicated, but it's an intriguing study. This basically showed the patients to the kids, a pediatric study. The kids to the left got started on inhaled corticosteroids less than 2 years after the diagnosis of asthma. The kids to the right got started on inhaled corticosteroids, but it took the doc more than 5 years with a diagnosis of asthma. And what you can see, inhaled corticosteroids improve everybody above baseline, but the longer you wait, the less bang you get. The other thing we've learned recently in the last decade is that inhaled corticosteroids decrease hospitalization. If you're on inhaled corticosteroids, the more compliant you are, the less likely you are to be hospitalized. And similarly, Dr. Suisse in Canada did this study looking at sort of compliance and found that if you were compliant with your asthma inhaled corticosteroids, you were less likely to die of asthma. So inhaled corticosteroids are the primary thing that we use for asthma. However, they're not always used. I think one of the reasons is fear, particularly in pediatricians, particularly concerned about growth factors. This was the CAMP study that was done, published in New England Journal. This is an amazing study. Over 1,000 children, ages 5 to 12, followed for over 4 years. Now, if you've ever done research before, it's very hard. Pediatric research, impossible, because you have to pull these kids out of school and get the parents involved. Very hard to do. And to do it and follow them for 4 years and 1,000 kids, that's pretty phenomenal. What they did is they randomized these to inhaled corticosteroid, which is budesonide, a mast cell stabilizer, nandocromil, and placebo. Well, not surprisingly, their asthma outcomes were 1,000,000 times better when they were on inhaled corticosteroids. Fewer hospitalizations, ER visits, less prednisone, stuff that you would expect. But what was unexpected is that at the end of the study, there was no difference in standing height. Standing height was the same. What happens is in that first year, if you look at the graph to the right, you see the speed or velocity at which you grow slows down in that first year by about 1.1 centimeters, but eventually the kids catch up. So these are very, very safe. Montelukast Singulair was popular because it's a pill, it's not a steroid, but if you look at all the studies, it's actually not very good. It's not as effective against low-dose inhaled corticosteroids, against the newer inhaled corticosteroids. If you add it on to inhaled corticosteroids versus salmeterol, it doesn't do as well. So it's not a great drug. So one thing that was asked back in the late 90s, early 2000s is if you have someone on inhaled corticosteroids and they're not doing well, what's your next step? Do you up the steroid or do you add a long-acting bronchodilator? And so there are a ton of studies done with this study design where you either added the inhaled corticosteroid or double the dose, added the long-acting beta agonist or double the dose of the steroid. And what the study showed time and time again, this is looking at peak flow, is that both groups did better, but the addition of a long-acting bronchodilator was superior. This is symptom-free days. This is a meta-analysis of multiple studies using a similar study design, finding the same thing. This is a scatter plot looking at exacerbations, basically showing you the same thing, that combination therapy is superior to doubling the dose of steroid. So that's all I wanted to say about medication, the stuff that Dr. Stoloff was not going to cover. Next, hopefully Dana will be able to load from a thumb drive or a CD or a DVD the presentation that I was able to capture for you, and hopefully you'll enjoy it. Dr. Stoloff is a pretty good speaker, though I think this platform doesn't show him at his best, but it's a very good slide deck, and he goes over detailed the new guidelines. And again, if I try to post this to Blackboard, but the file is just too darn big. So with that said, I hope I see you sometime soon. And again, if there are any questions at all about asthma or obesity, email me and I will post sort of the aggregate responses to those questions in an email or something of that sort. Have a good weekend, and I hope to see you soon. Take care.